Welcome, everyone. Thank you for joining us today. We're just giving a few moments for everybody to join. All right, we're going to go ahead and get started. We're just going to take care of some housekeeping at the beginning. So, hi, everyone. Thank you for joining us today. My name is Catherine, and I will be moderating today's COVID-19 and behavioral health workshop. For audio description purposes, I am a Chicanx woman in her 30s with tan skin, brown and green hair, and I'm wearing a teal blouse. First off, if you'd like to access captions, go to the meeting controls at the bottom of your screen and select the CC icon titled Live Transcript. And you can click this option, the option Show Subtitle, to gain access to captioning. Alternatively, you can also use the stream text link that I have just dropped into our chat. This is a great option because you can change the font size, the font color, or make the captioning full screen. Please note that the chat is reserved for networking and interacting with one another, so have fun connecting, but any and all questions for our panelists should be entered into the Q&A located in the meeting controls at the bottom of your screen, or signaled with a raised hand, a function which is also located in the meeting controls at the bottom of your screen. If this is the most accessible option for you, go for it. We're reserving the last 15 minutes of our workshop for Q&A, and we'll try our best to address everyone's questions with the time that we have. Thank you for sitting through my bit of housekeeping, and I will now hand it off to the workshop.
Good morning. I am Sharon Nevins, and I am the Area Agency on Aging Director and Public Guardian for San Bernardino County. It is my esteemed pleasure this morning to welcome you to the California Coming Together Behavioral Health Conference Series. Our workshop is entitled Addressing the Behavioral Health of Our Elders During the Pandemic and Social Unrest, Supporting Integrity versus Despair. We have a very dynamic panel of highly skilled, highly trained experts in behavioral health who will be presenting to you this morning. Each of our experts have a wealth of experience and knowledge providing leadership to individuals throughout their respective communities in the area of behavioral health. I would like to start by introducing the panel members this morning. First, we have Dr. Veronica Kelly, my colleague from San Bernardino County. Dr. Kelly is the director for San Bernardino County Department of Behavioral Health. She is responsible for providing oversight for the mental health plan here in San Bernardino County, serving over 2.2 million individuals in the county. Dr. Kelly is the president of the California Behavioral Health Directors Association, and she is a proud member of many other organizations, including, but certainly not limited to, the Mental Health Planning Council. She was recently appointed as recent as 2019 to the governor, by the governor, to the No Place Like Home Advisory Committee. Dr. Kelly holds a master's degree from University of Southern California, and she has a doctorate degree from Capella University. We are very proud to have her part of our panel this morning. And I want to add that Dr. Kelly is back joining us this morning by popular demand. She was able to join us last year and speak on behavioral health along with her colleagues. And by popular demand via surveys, you asked that she return, and here she is this morning. So welcome, Dr. Kelly. Next, we have Ms. Tony Navarro. Welcome, Ms. Navarro. Ms. Navarro is the Executive Director for Tri-City Mental Health Authority. And one may ask, what is Tri-City Mental Health Authority? Tri-City Mental Health Authority is a public behavioral health agency responsible to provide the outpatient specialty mental health services to the cities of Claremont, Laverne, and Pomona, California. Ms. Navarro has over 30 years of experience and 20 years of providing leadership experience in behavioral health. She is a member of California Behavioral Health Directors Association as well, and she has worked with the public mental health system for a number of years. She is a licensed marriage and family therapist, and we're very happy to have her part of this panel this morning. Next, we have Dr. Savette Johnson. Dr. Savette Johnson is a licensed clinical psychologist and the appointed director for Ventura County Department of Behavioral Health, serving over 18,000 clients a year. Dr. Savette Johnson holds a master's degree in marriage family therapy, and she received her doctorate degree from California School of Professional Psychology. When asked what is Dr. Savette Johnson's passion, Dr. Savette Johnson really values and have a strong passion for diversity and equity. She is passionate about serving the unserved and the underserved communities and populations that exist throughout the county. She is one who ensures the voice of individuals are well heard and understood. We want to welcome Dr. Savette Johnson to this panel this morning. And as we move on, I would like to, first of all, highlight the fact that this conference is extremely important to all of us this morning. The past year has undoubtedly demonstrated the importance of behavioral health for all of us, especially on the lives of our elders, older adults, persons with disabilities, the individuals we all serve. It's also highlighted the nexus between mental wellness and equity in general. Let's start with a question to each of our panelists. I will be asking the questions and you will be hearing from each of our panelists as they respond to the question. So to that end, the first question, and it's going directly to Dr. Kelly. What local impacts have you seen with regards to behavioral health needs of our elders and elders of color?
Thank you, Sharon. So I'm Dr. Veronica Kelly. I am the light complected female who's in her 40s to 50s with a russet color jacket and glasses. So that's a great question, Sharon. In San Bernardino County and the Inland Empire in general, of course, we noted impacts of COVID and its specific impacts on our seniors living alone from a behavioral health perspective due to increased isolation. It was obviously very impactful for our elders who are residing in senior living or in skilled nursing facilities. And we did also see an increase in substance use disorder amongst our elder population of increased use and increased relapse. And this is obviously a taboo subject among many of our older generation. But I think above all, our elders, more so than any other generation, have had their grief process interrupted and lengthened. So they've had an interruption in the normal developmental process of preparing for end of life things. And that was specifically because all of our connections were effectively shut off during the pandemic and the lockdown, especially if there was bandwidth issues for our elders who are of lower socioeconomic status, if our elders were living in remote locations or had a lack of technical knowledge or technical equipment. But possibly the most profound could be when their peers died. Because they didn't have the ability to process grief in the normal way. Since funerals couldn't occur, we didn't have church or synagogue ceremonies. So we were not able to, and this happens to everyone, but because this is in particular something that is specific to developmental processes for our elders, they were left with no closure for the grieving process. So we can expect to see fallout, I think, for years of unresolved grief. And we're talking about integrity versus despair. One of my mentors, who's a man in his 80s, has always spoken about his fear of dying alone. He lost a child in infancy, divorced a few times, but he kept, especially during COVID, talking about how he did not want to get COVID and not have someone's hand to hold that he knew that was his connection to the earth, and that he was afraid was going to lead him to despair. And one final note is for our elders who fought so hard during the civil rights times in the 60s, 50s, and 60s, to see the social unrest happen, and without having any tangible advancements in that fight, that's also something that we think is going to be impacting that level of despair or grief, because we aren't where we wanted to be.
Okay, thank you, Dr. Kelly. Why won't we move to Dr. Johnson?
Thank you, Ms. Nevins. For purposes of my image, I'm brown-skinned African-American woman. I have on, looks like purple lipstick in your video and a string of pearls. So that's not giving my age. But so regarding this question, I'd have to say yes to everything Dr. Kelly just mentioned, because of course we saw that here. I think in terms of diagnoses, what did we see? A increase in our uptick, depression, number one. In 2020, I think our older adult population that we serve increased by about 5%, which is a big jump for us in 1 year for just our 60 and over population. Another thing that we saw is because folks were unable, and remember, older adults were the first population that was impacted with these stay-at-home orders. It was really sort of targeted to older adults. So, you know, at the end of March in our county, older adults were warned and encouraged to stay at home as much as possible. And that's continued even now, even with vaccines. And so you have some older adults, we have, you know, about 41% of the individuals we serve are Latino. So we have indigenous communities as well. And our older adults that are Latino, they're not in SNFs or board-in cares or long-term facilities. They're at home with family, usually children or another relative that's caring for them. And so you have these family groups that have been used to caring for their loved one, but they had respite. They had the adult daycare centers that their loved one went to occasionally a few times a week. We have our older adults program that they would go to on a very regular and consistent basis, where they socialized with their peers, where they had community and they had feasts and lunches and celebrated holidays and talked about the good old days and listened to music, you know, from past generations. And all of that all at one time stopped. And so not only do we have our older adult population isolated at home and sort of cut off, we also have families that have no respite, and they're taxed and they're tired as well. And so it's really, how do we engage those families to help relieve some of the stress that they're feeling, while at the same time attending to our older adults who also need to have some kind of hope, some kind of positivity during this very challenging time. So case management, our numbers absolutely skyrocketed. Why? Because our staff are going out to homes and really sitting with folks, doing crossword puzzles, because yes, telehealth was available and we utilized that in many ways. But for some of our older adults that aren't from that generation of being locked in on a screen and high tech, that just didn't feel right. It didn't feel appropriate. It didn't fill that void. And you could see that they were struggling. So we did some fun things with our clinic administrator of our older adults, Peter Schreiner. He created a book, like a handheld, tangible book. And it had the pictures of all of the staff, and it had inspirational quotes and crossword puzzles and things that case managers could go out and do with each of the clients in that program, because telling them to sign on to a Zoom, that really wasn't how they were used to connecting, and we couldn't just force that on them. So I think some of those things is that making sure that as we're opening back up, how do we do that? We used a lot of transportation contractors, and we had to buy some vans that were wheelchair friendly and accessible so that we could make sure it was a contained environment and safe for our older folks, but to bring them back in and to be able to start some safe social distancing socialization. We have our BC AAA program here. Victoria Jump is our director, and Monique Nowlin is our deputy director. And they were pretty amazing because, you know, overnight it felt like they were delivering meals to all of our seniors. And because we had already formed a partnership with them in 2019, we were already working with them with their Pearls program, treating depression and increasing functioning and quality of life in our elders. So I feel like because there were some things that were already in place, it really helped us to be able to serve our older adult population, even with no one being ready for what COVID brought us.
Thank you, Dr. Johnston. Ms. Navarro, can we get your perspective on the same question, please?
Yes, hi, good morning. Thank you so much. Thank you all who are joining us for today's webinar. So again, what Dr. Kelly already spoke of and Dr. Johnson spoke of were similar things that we saw here in the East End of Los Angeles County. We experienced, and many of our seniors were living alone, experienced the isolation, an increase in requests for formal services, mental health, and our seniors, really looking at those seniors who were living in multi-generational households. They, again, they were the caretakers, talking about integrity and despair, as Savette talked about. They were the ones who used to walk the kids to school or make sure the family had their breakfast and lunch. And those things were interrupted as families tried to adjust and panicked about, oh my gosh, this is an older adult illness, and we're actually isolating their seniors within their own home. So from that, we saw an increased need and request for services as well, and saw a significant uptick, as did Dr. Johnson's County. But what I want to illuminate was something a little different that we saw that no one has talked about yet, is that we also saw many of our seniors calling and asking about ways to help and ways to get engaged and really maintain their integrity, if you will. Pomona, Claremont, and Laverne is a very, very active social service community with lots of CBOs, and many of them focused on seniors. Two of our cities, Claremont and Laverne, have actually higher percentage of seniors than the county and statewide average per capita. So they're very engaged and involved, and we found them calling our community education trainers program that was doing webinars online. We started something called Community Chat, saying, how can we help? And we put together webinars about how to help spread the word about staying safe and during COVID and washing your hands and all those really important, clear information for folks, how to stay connected and how to do start a phone chain and all those kinds of things. And we found seniors really accessing those webinars at high levels, and also wanting to participate to share information about what they learned, so that they could also give back to the community and help them to maintain their integrity. And they also then wanted to come in higher numbers to our peer mentor program, which I'll talk about a little later, that was doing weekly calls to seniors. We started a referral list from the community and our staff in our agency, and people were assigned seniors to give calls to on a once, twice, or 3 times a weekly basis. So that was one of the brighter moments in COVID for us, was to be able to give our seniors something that they could do themselves, feel like they had some control and maintain their integrity and give back to the community.
Thank you, Ms. Navarro. Just want to pause here to say, for the purpose of imaging, I am wearing a black jacket with black and beige white colored pearls. So I just want to insert that.
Ms. Nevins, thank you so much. Tony Navarro from Tri-City. I am a Latinx woman with tan skin in my late 50s, wearing a navy blazer and in my home office. Thank you.
Thank you again. So let's move right on. How did County Behavioral Health pivot to meet these needs at a time when you were providing services to so many other vulnerable populations? So can we kind of respond to that? And once again, I'll start with Dr. Kelly.
Thank you, Sharon. So the county behavioral health, we're the safety net. And so we provide behavioral health services, mental health and addiction services. So as you just stated, we continue to provide those services in our clinics. We never shut down. But we're a poor county, and poor folk do things really well. One of those things they do is they stretch a dollar. So we've always been very effective in the Inland Empire in stretching our dollars. And we do that by partnering with folks. So we did a very specific partnership because we were concerned about some neighboring counties that had people actually walk out of skilled nursing facilities, the staff, because of fear of COVID, leaving elders in their beds to die. And so we did not want that to continue to happen. So we intervened. So the Department of Public Health worked with us, the Department of Behavioral Health, and our county hospital, Arrowhead Regional Medical Center. And we pulled together a skilled nursing facility outreach and support team. We called it SOS. And what we did is we took public health providers, we had a physician's assistant, we had our clinicians, and we went out to provide PPE, so personal protective equipment, to all of the skilled nursing facilities in our county. We went out to every one of them, cold called them. They were not necessarily happy about that initially, but they grew to love us. We brought out PPE. In fact, we distributed over 2 million pieces of PPE because they needed it. We assisted them, our hospital assisted them in creating policies and procedures about how they would handle a COVID infection. And for us, the most important part was, how do they tell families? How can they connect families so families aren't freaking out as well? And then what our department did, behavioral health, is we were there not to provide clinical counseling to the residents of the skilled nursing facility, but we provided it to the staff, because the staff were watching folks who they considered members of their own family perish because of COVID. And they were, of course, isolated and working around the clock, and they were burning out. We knew we needed to help them so they could help our loved ones. So we would be there, again, cold calling, going to all of our facilities so that we could provide that support. We had coordination and communication. We had calls with all of our SNFs as well, and all of our partners. And so what this actually did was, no facilities had to close or had to be evacuated due to lack of staffing support. It was closed, but they didn't have to do that. And we on site, we prevented staff from walking out. We provided resources for additional support, so ongoing counseling. And that SOS team has completed over 300 visits to facilities throughout our county. And those included skilled nursing facilities, but also adult residential facilities where some of our mental health clients also reside, adult care facilities, including memory care facilities, boarding care facilities, and congregate living facilities. We identified 95 facilities that had outbreaks or were considered hotspot facilities, and we assisted them in working through that. So it remains a time of great crisis, but we all came together because we knew this was a population that was so vulnerable. And again, we do what we do best. We just pulled all of our resources together to assist our community.
Thank you, Dr. Kelly. Let's move on to Dr. Johnston. Can you, Dr. Johnston, respond as well?
Sure. Thank you, Ms. Nevins. So I'm going to respond from two different places. I'll start with, how did we pivot? Because the question is, how did you pivot to provide services during this time? So I have to go back to 2018, because since 2018, the healthcare agency, which behavioral health falls under, has a disparities reduction committee. And we meet with community members. And the goal of that is to talk about, how do we increase the number of Latino individuals and Indigenous populations served? How do we do that? And working with respected community advocates and members, we map out plans, we study data, we implement, we look back and say, what was right, what was wrong, how do we tweak this? And our VC AAA has sat on that board since 2018. And so it's been really nice, because the voice of older adults has always been in that conversation. It's been really critical. And what it did is it prepared us so that when 2020 hit, the relationships between our two departments were already built. Staff already talked. We actually have a clinic administrator that's over older adults that sits on their VC AAA board. And we already had MOU in place, so that work was being done, and it was sort of seamless of, okay, how do we increase and just move forward? So on that front, I felt that because of those interactions and that relationship building with those two departments, we were well placed. Now, public health also falls under the umbrella of the healthcare agency. So we worked with public health a great deal, because once the tragedy first hit and the scare with PP came down, we learned that our Office of Emergency Services was sort of at a critical shortage of PPE. Well, we have a safety manager, and it just so happened he's sort of a pack rat. So when we had fires in previous years, he had stockpiled all of these N95 masks, and we had millions of them sitting in behavioral health storage. So what we were able to do is, because OES was short, we were able to work with OES to get everyone that was serving our population. So the SNFs, the boarding cares, any congregate care that was serving our population. And we set up sort of a log with them that they could get whatever they needed that we had deliver it to them. And so we had masks, we had the shoes, we had the suits. Remember, first everyone was wearing these hazmat suits because no one knew what you needed. But we had that, so we were sending that out. Then once the vaccine clinics first started, we set up a vaccine clinic here, and we were, opened it up to all of the boarding care staff, the skilled nursing facility staff. And so we just tried to lift the burden off of OES and off of public health as much as possible, because we have nurses, right? And so we set up clinics, and we sent emails out. I was the one who would send the emails out. This is what you need to register. This is the paperwork you need, and they would come. And so it really helped to make sure, one, that when vaccines were available, that they had a place that they can come. They didn't have to sign up to a website. It was pretty simple. And making sure that they felt supported, because instead of having to go through the traditional path of contacting public health, they could email one contact person, which was me, and I would be the liaison with public health, which I think worked really well. We're still getting a lot of emails, but it's the relationship building that makes sure that the providers are able to do their job without worrying about everything else going on in the background. And therefore, our clients and our consumers that are vulnerable and that really just need the attention of their providers, they're able to get that. So it wasn't just us, it was really a team effort. Our VC has gone above and beyond with the work they do, and we're just really grateful to be able to come alongside them and to join them in serving our older adult population.
Thank you, Dr. Johnson. Ms. Navarra, can we?
Yes. Hi. Okay. So Tri-City Mental Health, although a public behavioral health entity and part of the county behavioral health system, we look more to the outside world like a private nonprofit. So we do all of the services are not contracted out. They're all Tri-City staff that are providing the formal treatment services, prevention, early intervention across the 3 cities. And so the way we pivoted looks similar to how many of the partners that Dr. Johnson and Dr. Kelly talked about. We made sure immediately that we started to reach out and find out which one of our seniors, in particular, of course, had the capacity to pivot to telehealth. We reached out, we provided smartphones that had video capability. We actually had staff going and standing physical distancing in the home and walking them through how to set up their phone with the right application to do video sessions, or phone if they preferred. And we did those kinds of things, right? But then we looked at our specific programs for seniors and thought, okay, how do we pivot these to continue to give them the consistent care and attention that they need, because it's more critical than ever. One of our unique programs for seniors is part of our therapeutic community garden. We actually have a horticulture group therapy program and a site that is located next to our adult clinic. And twice a week, we have a very robust senior group of a dozen seniors in each group that come 2 to 3 times a week and participate in gardening as a mindful and healing exercise. So we were like, what are we going to do with that? And how do we do that? And our team came together and said, well, let's put together like 2 to 3 week session curricula. We'll put together little pots so they could do home gardening in their home. So what we did is we got on the list, and all the clients that wanted to participate, we actually delivered to them their own pots with soil and seeds, and created sessions online. They could participate by phone or video. It was very adaptable, and they continued to meet regularly for their therapeutic community garden sessions. Those were very meaningful for folks. In our peer mentor program, that has historically, as Savette talked about, Dr. Johnson talked about her program, something that was in place that just flourished during this time was we have a peer mentor program that started out catering to seniors, older adults, and college age students. But over time, what we found was that the peer mentors who were college age students preferred having older adult mentees that they called to check in with. These are persons who don't necessarily need formal services or who are stepping down from formal clinical services, but the cross-generational growth and connection that was happening between the college students and the seniors is something that's been going on now with us for almost a decade. And in this time, that really flourished because we had a lot of college students who were no longer on campus and were themselves really struggling with keeping isolation at bay, and how do I do something that keeps me busy. And we had more of them volunteering for more hours at the same time that we had seniors requesting more visits, sessions, and asking to be added to this program to have someone to talk to. And at the same time, we got more seniors asking to be then volunteers so that we could increase the base of that support. That program also then became a training ground for our cities, in particular, the city of Pomona, our largest city. They have a very robust senior lunch program at their public parks. And while they were continuing to deliver lunches to the seniors, the staff really didn't have training on how to have meaningful and deep connections with seniors. They would, serve them a meal and that was about it. So we did a lot of training with the city of Pomona Parks and Recreation staff who were part of the seniors meals program, and really helped them to increase their capacity to not just deliver nutritious food and keep people healthy that way, but how to have conversations in a meaningful way with the seniors that helped keep their mental health healthy as well. And then our wellness center, which is a community center that provides groups and programming, employment services for all ages. In particular, the senior branch. Similarly, they contacted all the seniors that had been coming to groups, reached out, took referrals from the clinical team and from the community for seniors to add to their programs. But one of the things they found that seniors were wanting was they, as I think Dr. Johnson mentioned, they missed or maybe it was as Dr. Kelly, they missed the in-person care, and they really wanted to be connected. And while we were able to do some of that on a limited basis, they created our first inaugural summer camp, senior summer camp. And the same way that we do for kids, they delivered a week's worth of activities and a curriculum. And each day, whether you did it, you could come online and do it with the group, or you could do it yourself and just, be private about it. There were activities to participate in, arts and crafts, some kind of literature, some music that folks could participate in together and share with the group. And so that was very successful. And I don't think it's just going to be senior summer camp, because people are asking for it to happen on a regular basis. So those are some of the things that we did to keep the seniors active and engaged. In addition to, as I said, providing more webinars and trainings and education so that they could then go back and give to their families and their community members.
So thank you, Ms. Navarro. So when we look at the mortality and morbidity data for the nation and the state, we continue to see people of color at the highest risk for severe illness and death based on disparate access to care and historic inequity. Can you each speak to that, please? Dr. Kelly?
Yes, that's a great point, Sharon. I sat along with some of your membership on the state's Community Vaccine Advisory Committee, and we were a committee of 100+ members. And this committee was drawn together to work on strategies with the California Department of Public Health to increase equity for vaccinations and testing. But the state was using a Healthy Places Index to overlay and to look at specific social determinants of health to determine what areas needed access more than others. The problem with the Healthy Places Index is that it doesn't use ethnicity as a variable, and it doesn't use disability as a variable. So those two big populations that are the most vulnerable, we're not explicitly called out. Now they do align because many of our people that we serve live in high poverty areas. But this was a message, it was a constant message that members of your community, as well as the behavioral health community, continue to call out to address equity for elders who need various strategies to access healthcare. And so what we saw was what we have always known, right? That people of color and elders of color lack easy access to high quality care. And that's due to the perceived racism and discrimination, as well as institutional racism and discrimination. So we had to not rely on the state to get this done so much, but all of us in our individual organizations, again, 100+ members, tried to develop strategies for how we could increase equity. So in our county, in San Bernardino County, we work through our senior centers and the Department of Aging and Adult Services under Sharon Nevin's leadership. And as Director Navarro stated, we went out to where seniors were. We went door to door. Sharon's group was out there really trying to serve elders and people who are living with disabilities in their homes, because that was safer than trying to get them to come out, not just because of COVID, but because they didn't trust us. And so this was super important. I felt as if we were simply just speaking truth to reality, that our elders need better access, and elders of color, the highest mortality group to die and suffer from COVID, need it more. In June of 2020, San Bernardino County's Board of Supervisors declared racism a public health crisis with a focus on dismantling racism. And that's a high bar, but that is a bar we must be striving towards, because racism prohibits equity, meaning not everyone is getting what they need, such as healthcare. So I'm really proud that we're a county that did that. Our focus now is to ensure that we keep doing that. We've got a long way to go, but I think COVID really was able to shine a light on inequity and disparities in access to healthcare, in particular for our elders and elders of color.
Thank you, Dr. Kelly. Dr. Savette, can we hear from you on that?
Yes, this is near and dear to my heart, because this is what I'm very passionate about. So when we talk about 2020, there were so many things happening. First, you saw the pandemic and you saw the impact that it had on communities of color. It was glaring. No one could ignore it. And we're saying, look at these, and every day we have a dashboard and we're looking at numbers, and we see our most densely populated and our poor communities, they're skyrocketing, right? Their numbers every day. And we're saying, what's happening? And we're looking at the way that we are trying to engage the community. And if you're looking at it, as in, this is what we do, and everyone wants to give you a hand clap. But if you're looking at it as, okay, but let's look at the outcome. What's happening? Is it reaching the target? No, it's not. So we're not doing something right. And it may be fine for in normal times this worked, or we thought it worked, but we're seeing the results of this is not helping those who most need our services right now. So how are we engaging? And so it really became a look and taking a magnifying glass to how are we doing outreach? How are we using our PIO, our public information officer? Where are we going to talk to folks? Are we going to places that individuals that need to hear from us, need to engage with us, need to understand information and education about COVID are at? And literally we took to the swap meets, we took to the Vallartas, which are like grocery stores, but they have everything in them, right? And we're agricultural county. So we have a lot of seasonal workers. We have people who are in the fields working that may not have the best working conditions. We have barracks housing for some of our farm workers where people were packed in there. And so there's questions of, well, why is there an outbreak? Well, let's look, people are in bunk beds and there's like 12 people in a 200 square foot place. This is not okay. And so we had to do a lot of education and informing about how do you engage communities of color? How, what's the register that the information going out should be in? Are we targeting Latino radio stations? When we're translating, what does that look like and who's doing it? So that was one of the things that came to light. The other thing, so we declared racism as a public health crisis in our county, and that was needed. But sitting on that committee, I was one of the vocal ones saying, okay, so what are we going to do? Because let's not form a committee just to form a committee and not show any work for it. So we're able to move forward and form some work groups with our sheriff. So there's a whole group on racial equity with law enforcement. And then there's a whole nother group focused on healthcare inequalities. And we have community members and advocates on that board who are able to provide real live input about where we need to be, how we need to engage. And I think that is so important. It doesn't do our communities any good for all of us who are government employees who are removed from certain types of situations and circumstances to talk about how we're going to engage folks. We need to hear from our communities. We need to hear from our consumers. And so that is something that is the work that I want to lift up, because when we talk about how do we improve access, it is not having a health fair on Thursday morning from 10 to 1. That's not realistic for the folks that we need to get to. What is helpful is to go to the swap meets on Saturday morning, or to be anchored out at a laundromat, or to go to the grocery stores. That's helpful. It's helpful to go out to the coffee shops where the older men who have all kinds of respect in the community, to engage them on a very real level and say, look, this is what we're trying to do. Can you help us? Can you invite us to this meeting? Because we have a message, we want to get out, we want to serve, but they're not going to come to our building to talk to us. And we understand and respect that, but can we have a seat at your table and be your guest so that we can then connect with your community? So I think that is the most important thing for me that's come from all of 2020, from COVID and from the racial and social unjust acts that we saw and the unrest that ensued because of it. And, they talk about, when things happen, it's not always smooth. Sometimes you need tension, right, to catapult people into action and to make things happen. And so I'm not happy for any of the events that happen, but I am glad that it stirred folks into action. And now we're having real conversations. We're really engaging our communities, and we're really hearing. We're listening and taking their lead, because we're not the experts of some of the populations we serve. We're just a guest in their life, and we need to respect that and act as if. Thank you.
Thank you, Dr. Johnson. Ms. Navarro.
Yes, thank you so much. And I'm not just going to say ditto to my colleagues, but because everything they said is just so vital. And I think we across the state saw the same outcomes from and results from what was happening in COVID. And I think collectively we came to some of the similar interventions and strategies to address racial disparity and inequity. But I want to take it to another side as well. So in my community, in my largest community, Pomona, I think Pomona is still to this day, I know in September they were ranked 3rd, and maybe now somewhere in the top 5 of the 88 cities in LA County had the highest death rate per capita from COVID-19, and predominantly, of course, people of color. Pomona has a higher than average Latinx, Asian American population than the county, and immigrant population than the larger LA County numbers. And my 2 other cities have, again, as I stated, larger senior populations, but they also have larger Asian American populations than the county average. And so we did see, unfortunately, as was the national statistic, more persons of color being negatively impacted by COVID, whether that be directly due to illness and death, or inadvertently as families being torn apart by grief and loss. And so we've had a lot of work to do there to really figure out how to get to communities and hear their voices and hear what they're going to need for a very long time moving forward. But another angle that I took was based on some work that we had already started around inequities and disparities in access and care for BIPOC individuals and families at Tri-City. And we started in 2019 to really bring implicit bias training to our agency, because so there's this quote by the poet Rumi that says, "Yesterday I was clever and I wanted to change the world. And today I am wise, so I'm changing myself." And I think that is how I come to leadership now as I'm older in leadership, that I look to the organization first to make sure that we have all of our ducks in a row and have the right mindset and framework from which to achieve the results we want, which is increase access. And I think one of the things that we sometimes just assume, especially at my level, is that everyone who comes into this work has some understanding about racial disparity and inequity. Why is it that BIPOC individuals are more overrepresented in the Medi-Cal system in our state? Why is it that there are racial inequities in healthcare and access and outcomes? It's not because of race and ethnicity, it's because of systemic racism and ongoing oppression. And so we really brought in training to help our staff back in 2019 COVID-19 to come to some awareness. And not surprisingly, we realized there was still a lot of misperceptions and people operating from being raised and being born and raised in a society here in the United States that values white over not, and that values Western European ideals of individualism versus community and collective healing. And so that is where we have focused a lot of our work in this space over the past year and a half, not just in getting to the right places and getting the message out, but in training staff to understand their own preconceived notions, for them to get educated about why is it that people are overrepresented, that people of color are overrepresented in all of these on the negative side of so many measures when it comes to health and wellness and COVID-19. And so that has been really important work. In addition, I myself brought together other health partners in the area to, as Dr. Johnson talked about, making sure that we had a group of providers and leaders in the area that were just health related, that we were all got on the same page about what do we need to do to increase health access and reduce disparities. And one of the foundational principles that we came to in some of my interactions with other leaders is they had really great intentions about how to help communities of color, but they were going about it in such a way that was pushing people away and creating barriers, and they weren't even aware of it. And some folks, even coming from a white savior perspective on how things should get done, were inadvertently cutting people off from the very access and information that they needed. And so this group took on that work of discussing how do we decolonize healthcare, if you will. How do we start to talk about implicit bias and structural racism within our systems for years, and our own policies, rules, and regulations that we had never really looked at. It's kind of like that image that we all saw sometime in high school in the class where it's a beautiful woman, but then when you look at it just slightly different with your eyes, it turns into an old crone. And once you've made the shift, it's hard to go back. So we're trying to help people make that shift to what really is the underlying causes for access and disparities, and then also looking at ourselves and making sure that we're not perpetuating those in the care, so that people trust us, feel like they belong in our systems, and feel like they're worthy of all that we have to offer.
Thank you, Ms. Navarro. So finally, what lessons have we learned from the past 18 months that can help all of us chart a better course for the future for our elders, older adults, persons with disabilities? Dr. Kelly.
So we all know what we've learned, because we've known about inequities and disparate treatment forever. But what we can do is we can make change quickly and safely if we want to. I think that's unfortunately where we are. We can do this if we want to. We need to build a better system for our elders. Absolutely, no question about that. And then we start that because we have the intention, we have folks who know what to do. What we don't have is funding. And COVID and our social unrest gives us cover to really push the governor and this current administration to get the dollars out to our senior serving providers. That's not where it's going. And I know that's political. I know this is probably something I shouldn't be saying out loud, but it needs to be said. We need to get the dollars to fund our area agency on aging, to really support our master plan for aging. And now is the time. So we have to really, again, we can do it if we want to do it. We just have to put in the work to do it. Another thing that we learned locally is that we had to leverage our Department of Behavioral Health's decades-long relationship with our communities of color in order to assist our partners in public health in doing something that they weren't as nimble in doing, and that's accessing communities where they live. They're used to perhaps having people come to a federally qualified health center to get health care. And that's not how many of our people, our communities of color, receive health care. So that's a really important thing, because I think we're going to have to build, we need the money, number one, but we also have to continue to work together with all of our partners to create more of a village mentality, which is not what we have now. We've kind of gone back to an individual mentality, and we can get back to a village mentality, I think we can do amazing things.
Thank you, Dr. Kelly. Dr. Johnson.
Thank you. Great question. I'm going to recap because in case people missed it, I'm just going to say this in case you missed it. So racism does exist in our systems. We learned that. If we didn't know it before, we learned it. I think we knew it before, but just to make sure we recap here. It exists in our policies, our protocols, the way we deliver services. If we think about how we deliver services, how we make someone eligible, how we deny eligibility, how we pathologize Western beliefs, right? Because like literally in the DSM, if someone tells you that God spoke to me or spirit spoke to me, you're going to have to pathologize them if you're going to give them a diagnosis. And we've taken away, we've said this a few times, but community healing is real. And so we have to go back and really sort of separate and differentiate out, okay, these are Western treatment options, right? And these are collective healing practices. And how do we move back to collective healing practices? Because when we talk about, disparities and inequities and access issues, there's also access issues because we are not offering what people believe in. We're not offering what our communities of color value. We're offering this individualistic, idealistic mindset. And for many, that is just offensive. And we have to respect that, but we're not respecting that if there's no alternative. So when there's no alternative, people will not come for the service. So we have to really get down to the root of who we are and say, how do we respect? I mean, really respect and showing respect, meaning embrace different treatment options. How do we embrace alternatives to care that may not look like what we've been doing? And honestly, that right now, Medi-Cal is not going to reimburse. So I mean, it's much bigger than just an county level, but that is what we have to go back to, because until we do that, there's still going to be inequities, right? Because our systems are not set up for people of color. And that's the reality. That's where we are. I don't know if people realize that 10 years ago or 5 years ago, but I think in the last year and a half, it's been made crystal clear that our systems are not set up for communities of color. So that's something that at a state level has to be addressed. It has to be mitigated. Otherwise, we're going to be going in circles because Dr. Kelly and Director Navarro and Director Nevins can work as hard as they want to in their counties trying to go around the system. But unless the structure and the foundation is built to support that, we are not going to be able to be as effective and dynamic as we need to be. And the dollars will not flow. So I think those are lessons learned. I think with CalAIM, we have great opportunity as we move forward. But this is not something that can just rest on our shoulders. This really is something the legislature will have to move on, right? Because we don't have the purse strings to manipulate this to make it work, even with all of our passion and all of our effort and want to do that work. Thank you.
Thank you, Dr. Johnson. Ms. Navarro.
Yes, thank you. And again, just reiterating what has already been said, I think the will and the intention from the system at the leadership level across the state is there. And the creativity and the innovation and the desire by many in our service area, and our service providers in our counties want to do that work. And as Dr. Kelly and Dr. Johnson said, the money needs to flow in that direction to help us do that. There's never going to be enough money for us at the county level to take care of all the needs that are emerging for seniors, and in particular seniors of color in the state of California as a result of the COVID-19 disaster. There is just not going to be enough. And at the same time, our many really engaged and relevant partners, our faith-based organizations, our CBOs that focus on community healing practices, they too can only do so much without having opportunities for funding to flow to them to support the work that they do. in service of these populations. I think, again, as the legislature looks to investing money in certain groups, our children and our youth are extremely important. We know how much they have been impacted. Really important to also look at how much our seniors have been impacted. The data is very clear across this nation. The most stigmatized and discriminated group of people is not an ethnicity, it's an age group. It is seniors. That is the most discriminated group in this country. And at the same time, they are also really the largest group at this time. We have baby boomers now. They are our largest population in this state. We have got to take care of that, because how we take care of our seniors will impact our youth and our children. Our seniors have valuable lessons to give. And as children watch how we take care of seniors and that the state prioritizes their healing, it will impact them and their future leadership as well. And if we do it right, we'll be able to really have a very healthy state moving forward. So I think collective impact and community engagement is something that I have benefited from in my 3 cities in this time. As I said, very engaged CBOs and social service agencies, and really have seen a lot of groups come together in collective impact strategies to carry the load of all those who are underserved and in need, including seniors and BIPOC communities. And then folks are saying, but I need more funding. I could do so much more and impact more if I did. So I'm jumping in on that call for us to really bring to our legislators and to our electeds the need for us to deal with seniors, because I think also housing is another piece of this on the back end that even prior to COVID was a crisis in this state. Homelessness, but homelessness of seniors for the last 3 years, the fastest growing unhoused population in our state.
Thank you, Ms. Navarra. I certainly want to thank the entire panel today. We've had a very fruitful discussion, a lot of information. I want to give an opportunity for the audience to ask any questions that they may have at this time.
Thank you. So we have a few questions. I'll go ahead and read them out, and you can direct them as you'd like to, Ms. Nevins. We have a question from Rosanna Guerrera. Will there be any longitudinal effects of COVID-19 on older adults, not only with mental health, but with the delay on major health issues?
Do we want to have maybe Dr. Johnson or Dr. Kelly to respond? Any of you, Ms. Navarra?
Yeah, I can start. I think the answer to that is a resounding yes, absolutely, unfortunately. And I think we've started to see that. I know we have 2 county hospitals here in Ventura County, and they opened up, once immediately they stopped all elective surgeries, and then they opened up elective surgeries. And what I hear, every time I talk to our CEO of the hospital is that they're still seeing that folks are not coming in. They're not coming in for the services they need, and they know who they are. They're calling them, they're outreaching, but folks are scared. And so they're still not coming into our ambulatory care clinics, and they're still not coming into our hospital for procedures at the rate that they were before COVID hit in March of 2020. And that can be disastrous. And I think we're seeing that now. I know we had a spike, I can't remember the disorder he called it, but it's something with the lungs and the chest and breathing. So is it COB? I can't remember, but he was saying that there was a spike in that the last 3 months, and they know that it's related to folks not getting the preventive care that they needed or were scheduled to have, and delaying and delaying and delaying. We're also extremely concerned about women, because we know in our county they have not been getting mammograms as they need to, and that's preventive. And we know, so age 40 or some 40, but 45 up, women should be getting annual mammograms, and that has not been happening, and it still hasn't caught up to pre-COVID time. So we know that folks are foregoing needed treatment, preventive care. And I think our hospital and healthcare systems are having a very difficult time re-engaging folks to help them to communicate a clear message of it's safe to come in as long as you're wearing a mask. We have protocols here, and cleanliness is top priority. I think our elders will definitely feel this more than the general population.
Thank you, Dr. Johnson. I want to punt another question to Dr. Kelly. We have another question in the chat. I can go ahead and read this one. How can area agencies with limited funding prioritize seniors, services to seniors or people of color?
So you all should get Sharon Nevin's phone number and her email. I would give it to you, but she'll kill me if I give it to you. But we don't have to put out big procurements, which cost a lot of money to do this, right? Volunteerism is such an integral part of our elder communities. And so that is an untapped resource. And you don't have to be, someone who's running around and still working to be a volunteer. My mom's 74 and she's, has difficulty ambulating, but she always goes to senior centers to provide the people who go there with some music therapy and other things. And that then in turn helps her, right? So volunteerism, and if we're looking at your local churches, use the community, the cultural brokers that are around you to engage communities of color. If you're someone who looks different than the community you're serving, it's going to be a little bit harder, but don't give up. Our communities of color are willing to give the majority population, or white folks, a shot, but only one or two. So don't mess it up. Don't make a promise. Promises are like babies, easy to make, hard to deliver. So don't do that. If you say you're going to do something, do it with intention, but include community, because I think both Savette and Tony have addressed this. It's not about me determining what you need, right? That's very patriarchal. We don't do that anymore, right? On Wednesdays, we smash the patriarchy. That's what my own motto. But we need to ask our communities what they need of us. And then we can provide not what they're asking, but the resources, the support, the political support, connect them with people in your board of supervisors or in your local, assembly or senate, so they can get their needs met, because our communities know what they need. We just kind of have to partner with them so they can get it.
And I think in addition to what Dr. Kelly mentioned, the partnership, but also leveraging the resources and collaboration with other departments, I think it's imperative that area agencies on aging partner with local behavioral health, other entities within their respective communities. We are serving literally the same population. There are older adults in behavioral health. There are older adults in the AAAs. So we need to pretty much merge our resources. I understand that the behavioral health, mental health plan allow for stakeholder engagement processes. And so we look favorable at that data very closely to really determine what new services need to be provided and how do we ensure access. So I just kind of wanted to add that to Dr. Kelly's statement. So do we have another question in the chat?
So we have a question from Victoria Jump. What can we all do to support you and to move the needle in regards to legislation, changes in policy, and funding?
Okay,
I think
Ms.
I
Navarro.
I'll just say for my jurisdiction, and I know we all have the same mandate as Mental Health Service Act funded providers, but I think engaging with behavioral health, like reaching out to us. We all have departments that are about community planning and community engagement, and we hold regular meetings, and when we have to write reports to the state, we have to tell them what our stakeholders are asking for. And I think there's also other various ways in the larger counties that Dr. Johnson and Dr. Kelly can speak to. We have advisory councils that report to our governing board, which is only city council, but you all have advisory councils. I think you talked about the VCA, Dr. Johnson, that really being a part of those, looking on our calendars, on our website, seeing when those meetings are being held and coming to the table with us is much more powerful than just us doing it alone, saying, oh, by the way, we had this group and they said that. You can be right there with us when we say. So.
Dr. Kelly, do you want to respond at all?
I think everything that Director Navarro just said, speak up. If you see something, say something, and say it over and over and over and over to us. Go to your board of supervisors. They don't like constituents to complain. So keep at it. Send them letters, show up, go to their Board of Supervisors meetings, make a public comment about the needs of our elders and even of your area agencies on aging. But you all should do that as private citizens, because the four of us have trouble with it. We want to, stay in our position so we can help move the needle on the inside, but we have to work as a team from the inside as well as the outside.
And Dr. Johnson, I understand that your AAA director asked a question, so
She
why
did.
don't we let you weigh in on that?
I think in Victoria Jump, she's been amazing. She comes to meetings with stakeholders when they have questions to help explain on BC AAA side, the regulations and what they're doing and how behavioral health is moving it forward. So we have it's very helpful. Sitting in my seat, I can say I feel very fortunate to be able to text her or email her and say, Victoria, this is what's happening. Can you help me with this? I got somebody from your board over here. Or, it is extremely helpful to have that communication, to know that we are able and willing to leverage resources when regulations allow that. And then if we need to be able to go to our board of supervisors or our CEO and say, look, we're working together doing this, and this is how we can be more successful. I have full confidence that that is a technique that we can and will use in the future. And I know it'll work because we've already done so much together. So I feel very fortunate where I'm sitting and our relationship with our BC AAA leadership.
Thank you, Dr. Johnson. So are there any other questions in the chat?
I do have a couple of more questions, and I have an attendee who has their hand raised, Rosanna Guerrera. If you'd like, I can unmute you. We already asked a question. I worried about that, that the hand was up from the question that got typed in the chat. So let's move on to, would it be all right to get the presenter's contact information for questions that may arise after the meeting? Wonderful workshop, everyone.
Yes.
Absolutely, we could do that.
Great. Okay, and we have an additional question from Russell Rawlings. On Tuesday, the California Department of Aging and CFILC presented the vision of a hubs and spokes model for aging disability resource connections. How can our approaches to all of these solutions include age-friendly disability, culturally competent solutions that can serve as behavioral health hubs?
So do any of you want to take a strike at that? Maybe Dr. Johnson?
Can serve as, I'm trying to understand the question. I don't think I have clarity enough to answer this. If someone, could they expand on that question just a little bit more?
I felt like my answer was yes. When I heard that, yes, that is a great, that's part of the hubs and the spokes, right? And how do we, I think through ongoing communication and collaboration, unfortunately, one of the things that COVID has done to us on the Zoom world is it kind of has places where we were collaborating more maybe became a little bit, it's a little bit harder. We have Zoom fatigue to break down the silos. But if we continue to, as you know, if you're not a healthcare agency as in Ventura or San Bernardino, it's really important, like myself at Tri-City, to find ways to stay connected to partners on a monthly basis in meetings and reaching out and making sure that I send emails like, hey, there's a great article. It was something we were talking about, and stay connected so that those hubs, those spokes can contain all of that behavioral health, wellness, health, racial equity, disparity, all in one place as we connect to the hub.
So Catherine, do you want to expand upon the question at all, or is that?
Well, I was actually going to say, I asked the person who asked the question, and they said that they would be happy to expand on their question. So I'm going to allow them to talk and they can voice it themselves. Go ahead, Russell.
Hi, this is Russell Rawlings. I am the statewide community organizer at CFILC. And Tony, I really appreciated actually your response. I think really kind of hit at I think the importance, right, of the approach given by the California Department of Aging was really to create fewer doors for people to have to go through, just for the very reason that you've mentioned, that kind of fatigue, right? And I think the more that we can create this one place for resources, the better. And I really, really hope that behavioral health will be a very plugged in part of this, because I do see that sometimes it's not by default a plugged in part. And I completely understand the value of all of the services being plugged into your advisory councils and all of those places. But I think that there is kind of a two-way conversation too that maybe could be set up with this new vision. And I hope that through the state's move and also the development of the master plan on aging, that these things can become more fully realized. But I just want to say that I support this idea fully, and also really appreciative that you're all here. So I hope that in your powers that you're able to ask the questions of how can we make more consolidated services and resources that are not in a separate silo. Thank you.
Thank you, Mr. Rollins. That was a very good question, and thank you for expanding upon that question. I don't know if Dr. Kelly want to respond to it with the understanding that I know that our AAA in San Bernardino County, we are very much dialed in with behavioral health. We are pretty much totally connected. And just listening to this presentation along this morning, I can imagine services to older adults, to elders, to persons with disabilities without behavioral health services. So this is a unique opportunity for us, a call to action, if you will, to actually partner with behavioral health on a systemic level as we look at embracing services, whether we're the hub and spokes or what have you, whatever door it is, or if it's a one-door approach, we need to have comprehensive array of services available to our older adults so that they can have so that they can easily access and navigate the system of care. So I don't know, Dr. Kelly, if you want to expand upon that at all.
Just everything you just said. I think sometimes behavioral health might not be as tuned into their area agency on aging, their AAAs, and it depends on the structure of a county. So for AAAs who are here or any elder serving agency, reach out to behavioral health because we love to talk to people, right? That is our bread and butter. We process, we love that. And we are all about strategy. That is our end game. We play long ball. So we are always strategizing. Sharon and I strategize all the time. How can I leverage my money so she can get her services? Because if her folks get their services, it reduces the costs on my end. And so you might have to come to the table with some of that to kind of get in the door. But our folks on the behavioral health side are always looking for strategy partners as well as collaborators.
So Dr. Johnson, I know that you're pretty much very much connected with the AAA in Ventura, and I know that you provide an array of services. Anything you want to add to Mr. Rollins' comment?
No, I would just echo everything. Yes, 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 we want to be tuned in. I think that the need for behavioral health and mental health in older adults will only grow because of the last year and a half that we've had. So we've got to be strategic, we've got to be forward thinking, and we've got to plan for sustainability. We don't want to do these one-off pilots that go for a year and you get the community used to it and it just goes away. We have to plan for sustainability. So that's where getting to the table, looking at budgets, how do we work with the system and the funding that we have to better leverage our dollars for the long game. I think changes are coming, and so hopefully funding will be coming down, but until we get there, that's where we are. And I think everyone should be on board with that. It just makes sense, especially given the last year and a half. There's no way anyone can deny that behavioral health can't be at the core of the services to our older population.
Thank you. Are there any other questions in the chat that we have time to answer?
Nope, that is it for all of our questions, and we are officially at time. That was a nice fit.
So once again, I want to thank all of you, and we certainly appreciate it. We look forward to ongoing collaboration and partnering together with our AAAs and behavioral health and CFIOC and other entities who may be represented on this presentation today. So thanks again for your time, and we certainly appreciate it.
Thank you.
Thank you. Thank you for having me.
Thank you so much.